সবাইকে শুভেচ্ছা ও স্বাগতম। আজকে কেস বেসড অ্যাপ্রোচ টু ভালভুলার হার্ট ডিজিজ, আমরা ভালভুলার হার্ট ডিজিজ সম্পর্কে জানবো। আর এই জন্য এই ক্লাস আয়োজন করার জন্য অ্যাক্সিস মেডিকেল স্কুলকে ধন্যবাদ এবং আমাকে অবশ্যই সুযোগ দান করার জন্য আই এম গ্রেটফুল টু অ্যাক্সিস মেডিকেল স্কুল। এখন আজকে যে আলোচনা আছে যে কেস বেসড অ্যাপ্রোচ টু ভালভুলার হার্ট ডিজিজ, আমরা আসলে কেস বেসড অ্যাপ্রোচ করব, সাথে সাথে আমাদের এভিডেন্স বেসও থাকবে। অর্থাৎ এভিডেন্স কি বলে, আমরা তো কেস বেসড আলোচনা করবই, তার সাথে সাথে এভিডেন্স কি, এভিডেন্স মানে রিসার্চ আমাদের কি বলে। আচ্ছা, এই প্রসঙ্গে ইয়েটা হলো যে আজকে আমরা ভালভুলার হার্ট ডিজিজের বেসিক ওভারঅল যে ভালভুলার হার্ট ডিজিজের রোগী কিভাবে প্রেজেন্ট করে, কেন কিভাবে আসে, তারপরে আমরা কিভাবে ডায়াগনোসিস করতে পারবো, হাউ উইল ট্রিট দ্য ভালভুলার হার্ট ডিজিজ অ্যাজ এ হোল, আসলে আমরা এটা নিয়ে আজকে ডিসকাস করব। ওভারঅল টোটালি ভালভুলার হার্ট ডিজিজ সম্পর্কে, পরে স্পেসিফিক ভালভুলার হার্ট ডিজিজ যেটা আমাদের আসলে কিছু কিছু জিনিস লাগবে আন্ডার গ্র্যাজুয়েটে, কেন আন্ডার গ্র্যাজুয়েট মাইট্রাল স্টেনোসিস বা আওরটিক স্টেনোসিস অথবা মাল্টিপল ভালভুলার হার্ট ডিজিজ, যদিও মাল্টিপল ভালভুলার হার্ট ডিজিজ একটু কম থাকে, তারপরেও স্পেসিফিকলি একটা বা দুইটা হার্ট ডিজিজের লং কেস কিন্তু পরীক্ষার সময় তোমার মোটামুটি থাকতেই পারে, ইভেন উইথ কমপ্লিকেশনস, যেমন মাইট্রাল স্টেনোসিস উইথ সিভিডি, সেরিব্রোভাস্কুলার ডিজিজ আর স্ট্রোক অথবা ওয়ান সাইডেড প্যারালাইসিস, এটা কিন্তু থাকতে পারে এই পরীক্ষার সময়, অথবা আওরটিক স্টেনোসিস উইথ সিনকোপাল অ্যাটাক, অথবা আওরটিক স্টেনোসিস উইথ সাম কমপ্লিকেশনস তোমাদের কিন্তু পরীক্ষার সময় এটা থাকতে পারে, অথবা পিওর ভালভুলার, অথবা আওরটিক স্টেনোসিস, আওরটিক রিগার্জিটেশন উইথ মাইট্রাল স্টেনোসিস, অথবা মাইট্রাল স্টেনোসিস উইথ আওরটিক স্টেনোসিস, মাল্টিপল ভালভুলার হার্ট ডিজিজ তোমাদের পরীক্ষার সময় থাকতে পারে। তাহলে ভালভুলার হার্ট ডিজিজ আসলে এতখানি ইম্পর্টেন্ট যে সাথে সাথে কিন্তু ভালভুলার হার্ট ডিজিজের ক্ষেত্রে আমাদের রিউমাটিক ফিভারও যেহেতু আলোচনায় চলে আসে, তোমাদের লং কেসে কিন্তু এটাও কভার হয়ে যায়। সুতরাং এই জন্য আমাদের ভালভুলার হার্ট ডিজিজটা কিন্তু জানতে হবে ভালো করে। মোটামুটি তুমি পরীক্ষার সময়, আন্ডার গ্রাজুয়েট পরীক্ষার সময়, ইভেন এফসিএস পরীক্ষার সময় মোটামুটি কেউ না কেউ একদম ডেফিনেটলি একটা কেস পাবা যেটা ভালভুলার হার্ট ডিজিজের একটা শর্ট কেস অথবা লং কেস, এবং মোটামুটি নিশ্চিত থাকো যে একটা শর্ট কেস থাকবে। এই জন্য আমরা আজকে ওভারঅল ভালভুলার হার্ট ডিজিজ আলোচনা করে স্পেসিফিকলি মাইট্রাল স্টেনোসিস এবং আওরটিক স্টেনোসিস এন্ড উইথ আওরটিক রিগার্জিটেশন নেক্সট আমরা আরো 2-3টা ক্লাসে আমরা ইনশাআল্লাহ আশা করি নিয়ে নেব। এখন এই যে ভালভুলার হার্ট ডিজিজের ক্ষেত্রে আসলে আলোচনা করার মানে জন্য যেটা আমরা ওভারঅল যেটা বলছি যে আসলে প্রথমে যদি আমরা ইটিওলজি আলোচনা করি যে এই ভালভুলার হার্ট ডিজিজের কারণটা কি, কেন ভালভুলার হার্ট ডিজিজ হয়, এই ক্ষেত্রে যদি আলোচনা করতে থাকি, তাহলে যদি আমি ওভারঅল বলি আমরা যে ভালভুলার হার্ট ডিজিজের ওভারঅল সবচেয়ে কমনেস্ট কারণ কি, আসলে ভালভুলার হার্ট ডিজিজের সময় যখন তোমরা আলোচনা করবা দেখবো ইনভেরিয়েবলি ইউ হ্যাভ টু টেক দ্য প্রপার ডিটেইলস হিস্ট্রি অফ দ্য রিউম্যাটিক ফিভার আর in the past history, if patient has any got rheumatic fever or not in their past medical history. In the past medical history সময় if you get any valvular heart disease especially in long case, then you have to have a details past medical history about their rheumatic fever heart disease. The rheumatic fever তাহলে is the commonest cause of valvular heart disease. The valvular heart disease এর ক্ষেত্রে আমরা rheumatic fever কে বেশি কনসিডার করব। এছাড়া আরো যে জিনিসগুলো আমাদেরকে কনসিডার করতে হবে সেটা হলো যদি দেখা যায় ইয়ং একটা পেশেন্ট আসে যে লেস দ্যান 20 ইয়ার্স অথবা লেস দ্যান 15 ইয়ার্স নিয়ে আসছে, সেক্ষেত্রে আমাদের কনজেনিটাল হার্ট ডিজিজ এটাকে একটু কনসিডার করতে হবে যে দেয়ার মে বি ইটিওলজি অর দেয়ার মে বি কজ অফ কনজেনিটাল হার্ট ডিজিজ দ্যাট ক্যান কজ ভালভুলার হার্ট ডিজিজ। তাহলে আমরা যদি একটু একটু করে ধরি যে আসলে কোন ধরনের কনজেনিটাল হার্ট ডিজিজ, কোন ধরনের ভালভুলার হার্ট ডিজিজ করে, সেক্ষেত্রে যদি আমরা aortic stenosis কথা চিন্তা করি যে aortic, in case of aortic stenosis there may be bicuspid aortic valve, especially bicuspid aortic valve is a congenital heart disease. We all know that there is a aortic valve, seminal valve, that is there is a seminal valve and there is a three cups, tricuspid seminal valve আমরা বলি যে tricuspid valve, এবং এই ট্রাইকাসপিড ভালভ জন্মগতভাবে বা কনজেনিটালি দিস বাইকাসপিড আওরটিক ভালভ পেশেন্ট মে হ্যাভ টু কাস্প। সেক্ষেত্রে টু কাস্প হলে ভবিষ্যতে এই টু কাস্পের জন্য পেশেন্টের আওরটিক স্টেনোসিস ডেভেলপ করতে পারে এবং আওরটিক স্টেনোসিসের মাত্রা হতে পারে সিভিয়ারিটি ফ্রম মাইল্ড মডারেট টু সিভিয়ার হতে পারে। তাহলে এখন এই যে তাহলে আমরা বলছি যে আওরটিক স্টেনোসিসের ক্ষেত্রে বাইকাসপিড আওরটিক ভালভ মে বি cause of congenital heart disease. এছাড়া আমাদের আছে supraortic membrane, subaortic membrane, there may be congenital supraortic membrane বা subaortic membrane এর এরকম থাকতে পারে যে there is a membrane above the aortic valve level that is within the arch of the aorta, or there may be a ascending aorta, or there may be a subvalvular membrane. So it থাকতে পারে যে লেফট ভেন্ট্রিকুলার আউটফ্লো ট্রাক্টে যেটা আছে, লেফট ভেন্ট্রিকুলার আউটফ্লো ট্রাক্ট মানে হলো লেফট ভেন্ট্রিকুলার আউটফ্লো ট্রাক্ট আর aortic valve মাঝখানে there may be a membrane that is called subaortic membrane, and that can cause obstruction of the blood flow from the LVOT or left ventricular to the aorta, and that may present with the aortic stenosis. Features like aortic stenosis, leg feature net, there may be a presentation of the left ventricular outflow tract obstruction. তাহলে এই যে আমাদের যেটা হলো যে aortic valve-এর ক্ষেত্রে আমাদের congenital যে সমস্যাগুলো আমরা আলোচনা করলাম, যে জন্মগত সমস্যা, এটা aortic stenosis হিসেবে প্রেজেন্ট করতে পারে, মানে valvular heart disease হিসেবে প্রেজেন্ট করতে পারে। আর যেটা আছে যে mitral valve-এর ক্ষেত্রে, mitral valve-এর ক্ষেত্রে there may be some congenital causes, যেমন আমাদের mitral valve-এর টার্মিনোলজি একটা আছে যে প্যারাসুটের মতো দেখতে অনেকটা, সেক্ষেত্রে হলো patient may have some congenital mitral stenosis. This congenital mitral patient may present with mitral stenosis like a parachute valve. আমরা ইকোতে প্যারাসুট ভালভের মতো দেখতে পারি। তাহলে এখন আমাদের mitral valve congenital cause থাকতে পারে, there may be tricuspid stenosis, congenital tricuspid stenosis, there may be pulmonary stenosis, congenital pulmonary stenosis. তাহলে pulmonary stenosis কিন্তু congenital খুব কমন, অথবা এটা হতে পারে যে আমাদের congenital আমাদের সাম সিনড্রোম আছে, এই সিনড্রোমের পার্ট হিসেবে কিন্তু mitral pulmonary valve stenosis থাকতে পারে, অথবা tricuspid stenosis থাকতে পারে, কিন্তু যে প্রেজেন্টেশন হিসেবে থাকতে পারে যে as a part of the সাম সিনড্রোমস এর মতো সাথে, মানে তার অংশ হিসেবে সেটা থাকতে পারে। তাহলে আমাদের congenital heart disease সম্বন্ধে কিন্তু আমরা জানলাম ডিটেইলস, যে আমাদের congenital আমরা যে কি congenital some causes of valvular heart disease সম্বন্ধে আমরা জানলাম। এখন আমাদের যেটা আছে যে এরপরে এটা হলো সাধারণত ইয়ং এজ গ্রুপ, যারা তাদেরকে আমরা then will suspect there may be congenital causes of valvular heart disease if patient presented within the early years. If patient present valvular heart disease like features in the middle age, then usually will suspect this patient may have some rheumatic heart disease causes, some rheumatic causes. There may be some history of rheumatic fever in his or her previous medical history. In that case, patient may present with valvular heart disease with rheumatic cause in the middle age group. এই ক্ষেত্রে হতে পারে কি patient in case of mitral stenosis, there may be or mitral regurgitation, there may be some rheumatic causes, or aortic stenosis, aortic regurgitation, tricuspid regurgitation, pulmonary stenosis, pulmonary regurgitation, patient may present with. But rheumatic fever usually mostly affect the mitral valve, then aortic valve, and tricuspid valve and pulmonary valve, they are rarely rarely involved in case of rheumatic fever, and rheumatic fever rarely affects pulmonary valve and tricuspid valve. So usually, commonly, mitral valve and aortic valve are affected by the rheumatic fever. So if there is in a middle-aged person, he presented with rheumatic heart, present with mitral stenosis or aortic stenosis, the cause may be rheumatic in origin. In the later age group, in case of aortic valve also, patient may present with aortic stenosis or aortic agitation, and due to rheumatic origin. And in the later age group, patient usually present with a valvular heart disease due to some degenerative causes or degenerative valvular heart disease, degenerative cause. Degenerative cause, this is some older age, there is degeneration of the valves, especially in these cases, aortic valve is most commonly affected. In that cases, patient may present with aortic valve or aortic stenosis or aortic regurgitation, and but rarely mitral valve is also involved. In case of there is usually calcification of the mitral annular calcification, and patient usually present with mitral stenosis or mixed with mitral stenosis and mitral regurgitation. That may be mixed mitral valvular heart disease. in that case, actually, in the older age group, usually aortic valves are affected, and aortic valves are usually affected in the degenerative causes. And then actually valvular heart disease is usually two types. They produce two types of pathology actually. There may be some stenotic feature, or there may be some regurgitation features. What is stenosis feature? Stenosis means there is narrowing of the valves. So there is obstruction of the flow of the blood flow from one chamber to the another chamber. In case of mitral stenosis, there is hindrance, or there is obstruction of the blood from left atrium to right left ventricle. And in case of aortic stenosis, there is obstruction of the blood flow from the left ventricle to the aorta. So pathology may be two types actually. There is a stenotic type, and the other one is regurgitation type. What is regurgitation type? The regurgitation means that is leaking of the valve actually. So in that case, aortic valve may be involved, that is called aortic regurgitation. Mitral valve may be involved, that is called mitral regurgitation. And there may be tricuspid regurgitation or pulmonary regurgitation also. If our tricuspid or pulmonary valves are affected, and there is a leakage of the valve. Actually, these are the two types of pathology in the case of valvular heart disease actually. And then if we see the two cases, one case is mitral stenosis. Then if we see how this mitral stenosis case may present, or how in which age group usually mitral stenosis cases present, and what are the physical findings of the mitral stenosis case, and what are the actually investigation findings, and how the echocardiographic findings, and how actually a mitral stenosis cases should be treated. And that is actually a sample cases of valvular heart disease. A 23 years old lady presented with. So what information we are getting from this line? A 23 years old lady, that is a young ladies. So lady, usually female, are more affected in case of mitral stenosis. We are getting this information from this case report, and usually patient present in the young age group, actually more younger age group, middle age group, like 23 years old lady. And how they are usually presented by mitral stenosis patient: shortness of breath on exertion and increasing intensity for last 3 months. So shortness of breath is an important. The patient usually present with shortness of breath on exertion. There is patient usually complains they feel shortness of breath, or they feel difficulty in breathing usually when they actually when they are walking, or when they are doing some works after especially taking meal, or when they are actually taking the upstairs to go upstairs. They feel actually exhausted, or they feel actually shortness of breath. In that case, on exertion, especially in any type of exertion, patient may feel shortness of breath. And actually, this shortness of breath, according to the involvement of the valve, that is intensity of the valvular lesion, usually that is increasing in intensity gradually day by day. Actually, as patient in the first in the earlier life, actually, patient may have mild mitral stenosis. In the latter latter age, patient may turn from the mitral mild to moderate to severe cases. So the severity of the shortness of breath is usually increasing day by day due to the involvement of the valves, or there is actually deteriorating of the valve condition depending on the deterioration of the valve condition. Patient may experience increasing intensity of the shortness of breath. And on examination, patient is dizzying, pulse 110 beats per minute. Usually, patient is tachycardiac also, and pulse may be regular or irregular. If patient has mitral stenosis, long-standing mitral stenosis, in that case, patient may have atrial fibrillation, and atrial fibrillation can lead to the irregular pulse. In that case, you can get irregular pulse if patient has atrial fibrillation with mitral stenosis. And his blood pressure is normal, respiratory rate 30 beats per minute, diastolic thrill in apex. You may get there is diastolic thrill on palpation in the apex usually, or in mitral area actually. And a faster sound is loud. Usually we get that there is a due to thickening of the actually a mitral leaflet. Usually you get faster sound. Loud, faster sound, and mid-diastolic, there may be mid-diastolic murmur in the apical area based on left lateral position, basal expression. So on physical examination, on our pre-code examination, on auscultation, usually you get there is a murmur. Which type of murmur this is actually diastolic murmur. How this diastolic murmur is best heard. Usually the best heard is the bell of the stethoscope, and patient in left lateral position and basal in expiration. So there is 3 points. So we'll best heard, patient is left lateral position is left lateral. So part of the stethoscope, which part is used? Usually bell of the stethoscope is used to hear as it is a harsh sound. There is rough sound. So rough rumbling murmur. So we can better hear the sound by bell of the stethoscope. What is the relation with the respiration? So relation with the respiration is that best heard with the breath holding expiration. So these are the actual point of murmur. And when you will present your case in the short case, especially, or your long case, you should utter all these points when you will describe the murmur, especially mid-diastolic murmur or murmur found in the case of mitral stenosis. You have to utter, or you have to tell all the points. Actually, what points you are getting, but you should get the whole all the points, and then you have to describe all the points in the examination in front of your examiner or teacher actually. And on ECG, patient has sinus tachycardia, and all you can get atrial fibrillation if patient has got atrial fibrillation with long-standing mitral stenosis. And chest X-ray PAView, usually what are the findings? Usually we get a patient with mitral stenosis in the chest X-ray. Actually, we'll get all the fissures in the, actually most fissures in the left border, also in the right border. On the left border, what findings we are getting? Usually we getting there is a strengthening of the left border. A strengthening that is straight the left border, because the curves, this ups and downs, concavity, convexity, these are convexity lost. Why this convexity lost? Because there is enlargement of the left atrium, left auricular enlargement. That auricular enlargement causes the filling of the left auricular space. There is a filling or outward bulging, and due to pulmonary development of the pulmonary hypertension due to long-standing mitral stenosis, so there is a pulmonary bay or concavity. That is, concavity turns into the convexity, or this concavity is lost, or this concavity is filled up, and this concavity is bulged outwards, maybe, or there is the fullness of the concavity or pulmonary bay. So these are the findings of the left border. Hot findings will get in the right border. Usually there may be double right border actually, due to one border is due to right atrial border, and the other border is the new border. We'll see the actually we do not get this. It's a normal people on normal X-ray. The other border in the near to the right border, we will get another border, and this is due to the actually this border is due to enlargement of the left atrium, When there is enlargement of the left atrium, this enlargement of the left atrium, this expands all the way. It expands upwards, expands towards the right, expands toward the left. Even usually the direction is the three ways, because there is in the lower part there is a left ventricle, so there is not any space to grow or to expand in the lower part. But this left atrium can expand. If expand in the upper part, then the widening of the carina occurs. Carina, because what is carina? Carina is the angle between the left or right principal bronchus. Or are the left and right principal bronchus? These are the part of the trachea, and trachea in the lower part, trachea divides into two bronchus: left principal bronchus, right principal bronchus. And the angle in between the right and left principal bronchus, this is called arena. And this below this carina, actually left atrium lies. When there is an enlargement of the left atrium, so there is a widening of the carina. Carina angle is widening, and due to upwards the enlargement or upwards displacement or upwards expansion of the left atrium actually, and due to expansion of the right side towards the right, there will be two right border actually. There is formation of the two right border, and the density in the right side of the heart, where there is a right atrium actually or lies, or there is a right border, there may be more density due to expansion of the left atrium also. And due to if it expands, it expands actually behind actually, or backwards actually. If it expands backwards, then it compresses on the esophagus, and the patient may present with also dysphagia. Patient may present with patient with mitral stenosis may present with dysphagia. Why patient present with dysphagia? There is difficulty in the swallowing. Why there is difficulty in swallowing? Due to enlargement of the left atrium. This left atrium pushes on the esophagus, and this pushes actually backwards, and that can causes that dysphagia. So patient also present with dysphagia. Actually, we can get displacement, or we can see this displacement by doing a barium mill X-ray. The barium actually barium follow through of the esophagus. This is called barium follow through of the esophagus. A barium mill of the X-ray or a barium mill X-ray. So by barium X-ray, we can see this is backward displacement of the esophagus actually behind due to enlargement of the left atrium actually. And when this left atrium usually expands in the left side actually, so there is an element of the left auricle, and we'll get the actually extending of the left border. There is actually there is depression in the left auricular side. Is actually there is a fullness or outward bulging, and this can produce the extending of the left border actually, and we'll get it in the X-ray. So these are the X-ray findings actually, and on echocardiogram patient will see in these cases there is severe mitral stenosis with moderate pulmonary hypertension. Actually, long-standing mitral stenosis can lead to the development of the pulmonary hypertension actually, and with some Wilkins echo score 6. What is Wilkins echo score? This is the echo score actually. We can scoring the mitral valve, condition of the mitral valve actually, and we'll see different parts of the mitral valve, and doing this scoring to see the there is a candidacy for the PTMC. Patient is eligible for PTMC or not. Actually, we will see this echo scoring to see the eligibility of the PTMC. PTMC means Parkinson's transluminal mitral commissurotomy. So there is a lot of modalities of treatment of the mitral stenosis. If patient is mild mitral stenosis, actually only medical treatment is necessary. Medical treatment is enough. In that cases, we offered medical treatment to the patient, and actually we are giving some drugs and some suggestions, some general measures to prevent the further progression of the mitral valve from mitral to mild to the moderate or severe cases actually. This is the option in case of mild mitral stenosis. But in case of moderate or severe mitral stenosis, and patient has got some symptoms, that is shortness of breath on exertion, and patient not responding the medical treatment well, in that cases actually what treatment we will do in that cases, we have actually two options. One is interventional options and the other is surgical options. That is intervention approach means without cutting the sternum or without cutting any the chest, we can treat this patient by balloon valvotomy. That means the balloon just by femoral route. We can the femoral vein is venous route actually, and we can just commissure. There is a splitting of the commissures, and when there is commissural fusion occurs due to, that causes the mitral stenosis. So we'll split the commissure, and we'll get the enlargement of the actually opening of the mitral valve actually. And so there is opening, so enlargement of the opening of the mitral valve. So there is a mitral valve area enlargement, and patient symptoms is really usually relieved, and patient has got a larger mitral valve area usually after doing PTMC. So PTMC in an intervention process, and this is a very much comfortable procedure for the patient also, and we can easily avoid the surgical morbidity and mortality in case of moderate mitral stenosis. And the other models of treatment is the surgical option. Surgical option, there may be OMCs, there may be CMC, or maybe mitral valve MVR, mitral valve replacement. If the valve condition is severe or valve condition is more deteriorated, in that cases, actually we'll do mitral valve replacement. But in the previous time when PTMC is not available, in that cases, actually we do CMC, closed mitral commissurotomy. Closed mitral commissurotomy now actually rarely, surgeons are rarely done. By closed mitral commissurotomy means actually by there's cutting the in the skin and the muscles in near the apex of the heart, and there is a cutting of the muscles of the apex of the heart. A dilator is introduced from the external to the internal of the heart, and also to the through the mitral valve. And there is a splitting of the mitral valve actually by some dilators, Hagas dilators. So by doing this dilatation, there is a splitting of the commissures occurs, and patient may get relief. But it is a surgical procedure actually, because we have to just close the apex of the heart, and we have to also close the external of the muscles, skin, and some other tissues that are actually opening by this procedure. So this is another option, and another option is OMC, open mitral commissurotomy, and this open mitral commissurotomy is usually done when there is a left atrial thrombus. In that cases, left atrial thrombus are also removed, as well as actually, and commissurotomy is also done. And in case of mitral valve replacement, if there is a left atrial thrombus, or there is a valve condition is worse, or if there is a associated with stenosis, regurgitation, or you can see co-score is more, that is more than 8 or even more than 10 or 12, then in that cases actually we do a mitral valve replacement. So how actually from this case, actually mitral stenosis is well described here. So we are discussing how in which age actually mitral stenosis presents, and which gender is actually more involved, and how this patient present with mitral stenosis, and on a physical examination, what the findings usually will get, and on investigations like ECG, chest X-ray, and echocardiogram, what findings actually we get in a patient with mitral stenosis, and what are the modalities of treatment we are giving to a patient suffering from mitral stenosis in varying degree. Actually, and that is well discussed here. Next, another case. This case is aortic stenosis, and this is one type of valvular heart disease. And a 53 years old gentleman present with shortness of breath on exertion for the last 2 years, increasing intensity for the last 3 months. So, what information actually we are getting from this case report in a patient having aortic stenosis or suffering from aortic stenosis, a 53 years old gentleman. That is an older age group. Patient may present with aortic stenosis in the older age group due to some genetic cause. We have already discussed in the earlier part of my lecture today that in case of aortic stenosis, if patient present in the earlier age group, usually congenital valvular heart disease the cause, like bicuspid aortic valve. If patient present in the middle age group, that may be usually due to rheumatic in origin. If patient present with the later age group, that is elder age group, this older age group patient in that cases usually this is the case of designated cause usually, but maybe rheumatic cause or maybe due to even congenital cause may present in the latter part if there is a valvular stenosis condition and is slowly progressing. In that cases, patient may face even in rheumatic origin or congenital patient may present in the latter part of their life. So, a 53 years old gentleman, so aortic stenosis in general, if it is a degenerative cause, usually it occurs males are predominant than females, and if it is a rheumatic origin, usually all rheumatic valvular heart disease, usually rheumatic fever females are more affected by rheumatic fever. So rheumatic valvular cause is common in women or female age group. And patient present shortness of breath and exertion for the last 2 years. So this patient may present with shortness of breath 3 months. So how a patient of the aortic stenosis may present? So this patient may present with shortness of breath, or even patient may present with syncope. Then it means that is transient loss of consciousness, or patient pain also. So why this patient has actually chest pain in case of aortic stenosis? Long-standing aortic stenosis can lead to the left ventricular hypertrophy of the patient. So there is a left ventricular hypertrophy. So there is a miss of the muscles. Due to there is an increased demand, then there may be normal flow, but there is increased demand of the blood supply. There is increased demand of the oxygen and nutrition. So due to the increased demand, there is relative ischemia, and patient may suffer from chest pain without any coronary blocks or coronary stenosis. There may be no coronary stenosis patient, but patient may experience chest pain. In a case of aortic stenosis, due to long-standing aortic stenosis can causes hypertrophy of the left ventricle actually, and the left ventricle can cause hypertrophy of the left ventricle can cause chest pain. And there is maybe increasing intensity of the shortness of breath on exertion. And on examination, actually, he is dyspneic. He is dyspneic. A patient may have actually short breathing, pulse 120 beats per patient is tachycardiac. A patient may have irregular beat. So the patient may have atrial fibrillation also. And blood pressure 100/30 millimeter mercury. So, so what is the point here? If a patient suffering from aortic stenosis, so aortic stenosis is the low output syndrome, because due to aortic stenosis, blood from the left ventricle cannot eject properly to the aorta. So there is a small amount of blood is ejected from the left ventricle to the aorta. So there is a blood that lead to the, so there is a less cardiac output, and that led to the low blood pressure in case of aortic stenosis. So patient may have systolic blood pressure even less than 100 millimeter mercury. And in that case, why the diastolic blood pressure is so low? When we in a normal person or a patient with aortic stenosis, the diastolic blood pressure should not be so low. Patient may have blood pressure like 100 or 70 or 80 millimeter mercury if there is a only or solely aortic stenosis. If the patient has only aortic stenosis without any other valvular involvement or without any aortic regurgitations, patient should have low blood pressure and low diastolic blood pressure may or may be near to the normal. But if he or she has a diastolic blood pressure is so low, like 30 millimeter mercury, then we should always suspect this patient may have aortic regurgitation, because the aortic regurgitation can cause low diastolic blood pressure, and so there is a wide pulse pressure. So if a patient present with wide pulse pressure, then we always suspect this patient may have aortic regurgitation. So we'll see what is the diagnosis in the echocardiogram actually. I will see in the latter part. Respiratory 32 beats per minute, diastolic thrill in the apex. This diastolic thrill in the apex is the mitral area, and as it is the diastolic thrill in the mitral area, so we all know that in diastolic area, in apical area or mitral area, this diastolic thrill actually is due to the mitral stenosis. So this patient may have mitral stenosis also. As this patient has irregular beat, if this pulse is irregular, as we suspect this patient may have atrial fibrillation due to irregular beat, and that causes the irregular beat. So this patient may have mitral stenosis also, and this mitral stenosis can cause the diastolic thrill in the apex. And this patient had mid-diastolic murmur in the apical area. So actually this mid-diastolic murmur is due to the mitral stenosis. And early diastolic murmur in the left lower sternal area, we all know that early diastolic murmur in the lower sternal edge or third or fourth intercostal space, usually this early diastolic murmur occurs due to the aortic regurgitation answer. This is aortic regurgitation. What is the actually type of murmur in case of aortic regurgitation? Actually, we get early diastolic murmur in the aortic regurgitation. Actually, in aortic regurgitation, we get early diastolic murmur, and the site of this murmur is usually in the lower part of the sternal border, in the third or fourth sternal space. And what are the other findings? And there is systolic murmur in the aortic area. See, as this is systolic murmur in the aortic area, so this systolic murmur may be ejection systolic murmur, and we all know that ejection systolic murmur is a feature of aortic stenosis. But you have to remember always this thing that a systolic murmur aortic stenosis we can get throughout the whole murmur, but best hard start in the aortic area, usually in case of aortic stenosis. But you can get this murmur in the whole of the precordium. So when you get a systolic murmur, but if you can get a systolic murmur in the mitral area or pulmonary area or tricuspid area, always check thoroughly actually this murmur, if this murmur has got in other area or not, or where this murmur is best heard, or if there is any radiation of this murmur towards the neck actually, just palpate this or auscultate this murmur of the aortic stenosis throughout the whole of the precordium actually. So on ECG, patient has got atrial fibrillation, and chest X-ray PAV patient has a cardiomegaly, as this patient has multiple valvular heart disease, and echocardiogram shows severe mitral stenosis with moderate aortic. So these are the findings we are now getting. This patient has severe mitral stenosis with moderate aortic stenosis, severe aortic regurgitation with moderate pulmonary hypertension. So long-standing valvular heart disease, especially mitral valvular heart disease, can lead to the development of the pulmonary hypertension, and this got cardiomegaly due to the actually severe aortic regurgitation, as well as patient has got moderate aortic stenosis. And this all multiple valvular heart disease, especially mitral valvular heart disease, as well as aortic valvular heart disease, leads to development of the cardiomegaly, as well as all the features that I have just described. Describe all the features actually. And patient, so what are the modalities of treatment? What treatment associated as he has aortic valvular disease, that is aortic stenosis, aortic regurgitation, and he has got mitral stenosis also. So this patient underwent DVR, double pump replacement, because our very good, very well. So actually, these are the findings. These are the actually patient with aortic stenosis, with aortic regurgitation, with mitral stenosis actually. So from this case, we have learned that when actually aortic stenosis or aortic valvular heart disease patient may present, or even multiple valvular heart disease patient may present in which age group actually, and how this which gender actually affected by the aortic valvular heart disease, or degenerative cause of the aortic valvular heart disease, actually which gender are affected, and how this patient aortic stenosis or aortic valvular heart disease actually how this patient presents, and what are the physical findings we actually we get from a patient with aortic valvular heart disease, and what are the ECG and chest X-ray findings also, and what are the echocardiogram findings, how we can actually diagnose and what is the role of echocardiogram actually in case of valvular heart disease, and what are the treatment we should actually offered in this case, and after doing the treatment, how this patient is actually doing. So from here, from these two cases, we'll see that echocardiography with color Doppler is the gold standard treatment for one diagnosis of the valvular heart disease, to see the severity of the valvular heart disease, because treatment depends on the severity, because a lot of modalities of treatment actually present with a patient with valvular heart disease. We are not offering all the treatment to all the patients. So a single or definite treatment is for actually for definite degree of valvular heart disease. So degree of the valvular heart disease is very much important. So how many valves are affected, or which valves are affected, and degree of the valves involvements, and what are the even there may be some complications also of the valves. We can diagnose from the actually for echocardiography. If there is any left atrial thrombus in the mitral stenosis, we can see by echocardiography, and so there will be change of the models of treatment if there is a left atrial thrombus. So there may be left ventricular, we'll see ejection fraction. If there may be left ventricular diastolic dysfunction, in case of aortic stenosis, there may be diastolic dysfunction. In case of aortic stenosis or mitral valvular disease, there may be diastolic dysfunction. Even there may be valvular cardiomyopathy also. So even if this patient has got valvular heart disease, but then is associated with LV dysfunction, so treatment modalities is really actually there will be change. So echocardiogram with color Doppler is so much important, one to diagnosis of the valvular heart disease. So how many valves are affected and which degree or how much the valves are actually destroyed or how much they are actually affected. So degree of the severity of the valvular heart disease we can measure by actually color Doppler echocardiography. And according to the report or according to the findings of the color Doppler study, actually we are offering the mode of treatment to the specific specific person with a specific disease also actually. So now it is 7:53. I have 7 minutes in my hand. So there will be I'll discussing another case, and I think rest of the discussion and the specific heart disease, specific valvular heart disease with a specific disease pattern like mitral stenosis or mitral ligation, aortic stenosis, I think we can discuss in the next 2 or 3 lectures or next classes, inshallah. So mitral regurgitation, we all know and we have already discussed that pathology of the any valves. We know that there is a 4 valves: mitral valve, aortic valve, tricuspid valve, and pulmonary valves. And these 4 valves, actually there is 2 types of pathology. One type of pathology is stenotic pathology, that is there's narrowing of the valves, so there is obstruction of the flowing of the across the valve, and the other is that's regurgitation, that's the leaking of the valve actually. So as there is a leaking of the valve, we will call it regurgitation type of lesion. So lesion is 2 types, one is stenotic type and the other is regurgitation type. So in case of stenotic type, the actually presentation will be different from the regurgitation type actually. And treatment, diagnosis, they all are differ from the stenotic type to regurgitation type. Actually, there is a stenotic type, there is a actually blood flow, there is a obstruction of the blood flow from one chamber to another. So there is usually the low output syndrome, the patient have low output syndrome. But in case of regurgitation, the patient may have a high output syndrome, like aortic regurgitation, mitral regurgitation. So due to high output, patient may have heart failure or may occur heart failure easily, and patient may have heart dilatation, there may be cardiomegaly. So these we can get with valvular heart disease regurgitation type. And in case of obstruction type, as there is obstruction, and especially mitral valve area, there is obstruction. So there is a maybe chance of development of the thrombus due to slow flow from the late atrium to the left ventricle. So there is a chance of thrombus. This thrombus may get dislodged and this may be embolized, even embolized to the brain. That can cause brain infarction or stroke, or it may be embolized to the coronary artery, that cause myocardial infarction or heart attack, or it can dislodge into the mesenteric artery, that may lead to the development of the mesenteric infarction. Even it may goes into the lower limb, and that can cause an necrosis of the limb. Even it may lead to the amputation of the limb also due to obstruction. So there may be a lot of complications may arise if there is stenotic regurgitation type. So as a whole, this is the some actually some pathology, different types of pathology due to regurgitation from the stenotic type actually. So regurgitation lesion, patient may present with shortness of breath on exertion, or patient may present with heart failure also, features of heart failure actually. And this patient has got also history of CMC 20 years back and history of PTMC 10 years back. After CMC, in the early part of the actually practicing of the mitral valvular treatment in the earlier part of in Bangladesh, even after 20 or 30 years back when PTMC was not available in Bangladesh. In that case, usually surgeons have done CMC, and this was actually the treatment with patient with mitral stenosis. But nowadays, actually, we are offering PTMC. There is intervention treatment. There is balloon valvuloplasty in a patient with mitral stenosis. So and now this patient, after doing CMC 20 years back and PTMC 10 years back, now this patient has actually again symptoms actually, and now she is doing a pulse 118 beats per minute irregular, BP 90/70, low BP, respiratory 32%, diastolic 3 in the apex. Faster sound is soft. Soft means there is actually mitral regurgitation, and P2 loud. P2 loud means patient had pulmonary hypertension, and there is mid-diastolic murmur in the apical area. Base heart in the left lateral push, that this patient actually has also mitral stenosis. So there is a mixed valvular heart disease. Patient has also stenotic life as well as a regurgitation lesion actually. And ECG shows atrial fibrillation, maybe due to long-standing mitral stenosis that causes the left atrial enlargement. And there is a stasis within the left atrium that leads to the even atrial fibrillation can cause thromboembolic manifestations in a patient with mitral stenosis, without actually mitral stenosis. Atrial fibrillation patient actually prone to develop thromboembolic manifestation. There is a CHEST-SAPI vicious cardiomegaly extending on the left border, a double right border echocardiogram shows severe mitral stenosis with severe mitral regurgitation with severe pulmonary hypertension with Wilkinson score 13. That is high Wilkinson score. Due to high Wilkinson score, this patient actually offered mitral valve MVR, which is mitral valve replacement. As this patient has got mitral stenosis as well as mitral regurgitation. So this lady actually offered a mitral valve replacement. Upper mitral valve replacement actually patient is doing very good, very well. So now I think if you have any questions, I don't know if there is any officials of Axis Medical School is with me or not. If you are present with me, so and if any student or if any audience has any questions, please just ask me if you have any from Axis Medical School. So I'm just stopping sharing. So I'll give any actually chat box, no chat box. So is there any question from the Facebook? I don't know. So if you don't have any questions, actually we can just stop here, and hopefully we'll see in the next class, inshallah. So goodbye everyone. Good night.